Menopause is a natural part of aging, but it can cause a lot of discomfort, both physically and emotionally. And the changes in hormone levels can also drastically affect a woman's sex drive.
Welcome to Sex Care is Self-Care, a conversation on women's sexual health brought to you by the Patty Brisbane Foundation for Women's Sexual Health. I'm your host, Patty Brisbane. Today, we're discussing menopause and treatment options that can help women protect their long-term health. I'm joined today by Dr. Christine Vaccaro, Dr. Kelly Casperson, and Dr. Rachel Rubin. I want to welcome each and every one of you. As I said, I have the rock stars here this morning to talk about this very important topic. And so, Dr. Vaccaro, I know everybody out there listening is going to want to know, what do you guys do on a daily basis and why are you rock stars?
Thanks, Patty. I'm so excited about this podcast. My name is Dr. Christine Vaccaro, and I'm very honored to be a medical advisory board member for the PBF. I'm also a fellowship director for urogynecology, an associate professor of obstetrics and gynecology in Bethesda, Maryland. On a daily basis, I treat women's menopause symptoms, pelvic floor symptoms, urinary and fecal disorders. But what I really want everyone to know is I'm also a perimenopausal woman, and this episode hits really close to home, and I'm super excited. Before our special guests introduce themselves, I want to let the listeners know that you're going to be hearing today from social media urology rock stars. These women are all over the place on social media, and I'm so excited to have them on this episode together because it's going to be an amazing conversation. They are extremely highly sought after experts. So I'm going to let them introduce themselves, starting with Dr. Casperson.
Hi, thanks for having me. So on a daily basis, I take care of both men and women. And I really think that's where the urologists have kind of stepped to the forefront, because for me, hormones and sexuality is an equality issue. And we see that we don't treat everybody the same in these two departments of quality of life. And so to me, I think that's really where my platform has gone, of like, let's just treat everybody equally, where pleasure and sexuality is important and acknowledged, and hormones are important and acknowledged.
Dr. Rubin?
I am Dr. Rachel Rubin. I am also a urologist, and I'm fellowship trained in sexual medicine. I also take care of everybody. And so we believe very strongly in quality of life. And I always say I do four things. I deal with issues of libido, arousal, orgasm, and pain. And when menopause is a huge piece of that, and hormones are a huge piece of that. And so I'm in the Washington, D.C. area, and luckily I get to be near Dr. Vaccaro, who is just incredible. And luckily get to be good friends with Dr. Casperson, because it is not one doctor that you see once a year for 15 minutes that can take care of all of your menopausal issues. And so it's really important to educate people about this so that they can come informed and that they can get really high quality care.
I agree 1000%. It's about the education and the information. And that's why we're here today. Dr. Vaccaro, we're going to start with you. What is perimenopause? What is menopause? What's the difference? Where does this all start?
Yeah, and I love starting with definitions because I think that's really important to clear up things. So menopause is 1 year after your final menstrual period, and it signals the end of fertility. So for this reason, it's kind of terrifying, I think, for a lot of women. The average age is anywhere from 50 to 51, depending on the stat that year. For women who have had a hysterectomy, which is removal of their uterus, you can also confirm with lab testing to confirm menopause has occurred, but though this is not necessary. If a woman has had her ovaries removed before menopause, thankfully this is uncommon. This is surgical menopause, which is kind of a little bit different because it's so abrupt. Usually the symptoms are really severe and occur almost immediately. Again, I think menopause for women is kind of a terrifying thing because, again, fertility for most women is such a big component of youth and identity. And then they know a little bit, right, about the symptoms. They know that it's going to signal some other changes, especially in the genital area, that are occurring simultaneously. And we kind of cluster this under another term called genitourinary syndrome of menopause, which really focuses on the pelvic region, the reproductive areas, the vulva, vagina, bladder, et cetera. So really, I saw this cartoon a while back that really kind of sums it up, but that I love. It's two hens, two little chickens talking to each other, and one says to the other, "Menopause is easy. Once you stop laying eggs, they eat you." Just funny, because I think where our identity is, we are the ones that reproduce, and once reproductive capacity is done, it's kind of like, well, what's the purpose? And I think that sometimes is challenging for women. Perimenopause, on the other hand, occurs several years leading up to the final menstrual period, which is then menopause. So for most women, perimenopause is associated with bothersome symptoms, hot flashes, night sweats, etc. It started occurring in the mid-40s. The key difference in perimenopause is that there's still adequate amount of hormones remaining to get pregnant. So the ability to get pregnant is still present, because the hormones haven't hit sort of rock bottom yet. So that's the difference between the two.
Thank you. Dr. Casperson, how do the changes in hormones, in your hormone levels, affect a woman's body?
Yeah, it's a really good question, because I think, again, going down to definitions, people think menopause is a hot flash. And when the hot flash is done, menopause is done, whatever that means. Because really, people don't understand that this is a profound change in your entire body, not just in your ovaries or the ability to have a period. So our hormones are molecules that travel around our body and affect every organ system. And that's why after menopause, we start seeing drier skin, brain fog. Some people get heart palpitations. I'm just going through the body, naming all the different changes because of low hormones, right? So bone changes, which we can't feel, cardiovascular changes we can't feel. And then, like Dr. Vaccaro said, genital urinary syndrome of menopause, which can be profoundly bothersome to people. Bladder issues, sensitivity issues, dry vagina issues. So we really, just in the basic education, think estrogen and testosterone only do one thing or only work in some people. Instead, after we have menopause and all those hormones go down, we can have profound changes for lots of different things. People don't know, like ringing in your ear or an itchy ear can be a symptom of low hormones.
I have all those symptoms.
Sorry,
I think
we can help you.
Yeah, thanks.
Where do you live? See Rubin.
There you go. Dr. Rubin, let me ask this. Let's talk about hormone therapy. What is that all about, and how does it help?
Yeah, it's a great question. So I think, again, education is so important here. When people understand, I have discovered, doing this for a while now, when you give people, especially women, good, clear education about how their bodies work and what the risks, what the benefits are, what the data shows, they make excellent healthcare decisions for themselves, like excellent healthcare decisions for themselves. And we call this shared decision making. And again, Dr. Casperson and I love taking care of men, and we're trained as urologists where we are deeply rooted in shared decision making. Let me give you an example. If a man has prostate cancer and he says, you know what, I really enjoy my orgasm and ejaculate and I don't want to lose that, well, then we say, okay, well, that makes sense to us. We have other options to treat your prostate cancer than removing your prostate, which would make you lose your ejaculate. And so we believe in body autonomy when it comes to men. We believe in the ability for a man to choose and understand what gives him quality of life and what is important for him, and risks and benefits. And so similarly, we are taught now that it is safe to give men who have treated for prostate cancer testosterone therapy if they're feeling sluggish, low libido, if they're feeling problems. It's very commonplace among urologists. So I think why Dr. Casperson and I are so loud and vocal about the safety and the benefits of hormone therapy is because we see every day in our clinics how much good these hormones can do for people. I always tell my patients, I'm so pushy when it comes to trying to get you to understand why this may help, because I see the other side. When you say that you have no energy, that you have no libido, that your orgasm is muted, that you keep getting urinary tract infections, I see 6 months down the road, and I see you coming back to me and saying, Rubin, I'm great. I feel great. I love sex again. I haven't had a UTI in 6 months. Give me my refills, woman, because I see it every day in my clinic. And so does that mean every human on earth needs hormone therapy? Absolutely not. However, we are not even offering women the education about why they may benefit from hormone therapy, because a 15-minute office visit with your legs in stirrups once a year is not adequate women's health care. And so this is why we're trying to supplement on social media, because we're trying to get women fired up to hearing that like there's more to the conversation. And many of your doctors are practicing medicine based on studies from 30 years ago that are not correct, that were not interpreted correctly, and that actually give you false information, making you think something is true that is actually not true. So we spend a lot of time educating and explaining to people the benefits and the risks of hormones, because it is, just like Dr. Casperson said, it's not just hot flashes and night sweats, which last for a short period of time for some women. It's a bone fracture, a hip fracture at 88. It's getting up in the middle of the night to urinate and having a hip fracture because you fell and then you die. You have a double risk chance of death within that 1 year. I want to prevent that when you're 48. I want to treat you when you are 48 or 45, when you're Dr. Vaccaro's perimenopausal age. I want to treat you then, because I never want you to suffer. I want you to be Dolly Parton, in that outfit at 78, dancing, looking amazing, right? That's what I want for my patients. And I don't apologize for that. Like, I think it's, that was a long-winded answer. I apologize. But hormones, they're not all good or bad. They serve a purpose in all of your body, just like Dr. Casperson said.
I'm glad you were long-winded. We need to hear these things. We need to know it's okay to have this information, to be informed, and to know that when you go to the doctor and they are not giving you this information, find another doctor. It's okay. Find somebody that's going to work with you. All right. So, Dr. Vaccaro, are there different types of hormone therapy?
Absolutely, Patty. And I just want to, before I touch on that, I love that we have urologists here, because they highlight, Dr. Casperson and Rubin highlight the differences and the inequities between male and female healthcare. And I really, I appreciate their perspective on how and they're obviously, they're being such huge advocates, they're passionate advocates for getting the message out. And I just wholeheartedly appreciate them so much. All right, but to your question, yes, there are different types of hormone therapy, and there's actually several sort of different categories. So I'll go through them one by one. So systemic replacement versus local replacement. Systemic replacement is for the whole body. So you're taking a patch, and I'll go over all the ways you can do that, or a gel, etc. But you're basically helping the whole body. So your bones, your brain, your skin, eyes, bladder, overall well-being. Okay. For your entire body, versus local vaginal estrogen is really just for vaginal symptoms only. Sometimes helpful for the bladder as well, but really the localized tissue. And again, this vaginal estrogen is helpful for reducing pain with sex due to dryness and irritation, also helpful to reduce UTIs. So again, there's systemic for the whole body, and there's local just for the vagina and localized tissues. Next, there's different hormones that we can replace. So, there's estrogen, progesterone, and testosterone. So estrogen is the main one that typically is replaced for hormone replacement therapy. Progesterone is only replaced if a woman still has their uterus, and is only needed if a woman has their uterus. And then sometimes testosterone replacement, which I think we should do a whole nother podcast on, because it's a whole nother topic that deserves kind of its own, I think, discussion. And a fun fact I actually learned from Dr. Casperson was women actually have more testosterone in their bodies than estrogen, which I think is shocking to most people. However, compared to men, we have significantly less testosterone than men do. So I think sometimes we don't understand that testosterone, actually, we have more of that than estrogen in our body. So I think, again, testosterone replacement should have its own podcast and its own discussion, but I think it's on the cutting edge of hormone replacement therapy. Lastly, there's different ways to replace hormones. So there's FDA approved products, pills, patches, vaginal rings, intrauterine devices, and gels. There's also non-FDA approved products like pellets. And I think many women right now are resorting to pellets because they can't get help from their doctor. A lot of doctors right now are afraid of hormones still, but women are suffering, and they, again, have to sometimes break up with their doctor or go to Medi-Spas to get help. They pay out of pocket for pellets, and sometimes receive too much hormone. So I strongly recommend using FDA-approved products for improved safety. And also, again, there are doctors that will prescribe it. Generally, you have to search them up on the Menopause Society. I'll turn it back to you.
Great. Well, that leads me to Dr. Casperson. Is there any risk in hormone therapy?
Yeah, it's a good question. Because I think a lot of people spend a lot of time in indecision worrying, is it safe? Is it safe? Is it safe? And I always like to break it down for them of like, taking any medication has risks. But I think the average person doesn't understand that like a risk of a medication does not mean everybody's going to experience that, right? So again, I think it's like basic education of risks of taking medications. But when you think about what doctors prescribe to humans, any human, whether it's an antidepressant, anti-anxiety, blood pressure lowering medication, something to help you not clot your blood, statins, very common medications, they all have risks. And compared to a lot of medications that doctors prescribe, hormones are some of the safest medications that we can be taking. The reason for that is they're basically identical or matching what our body naturally produces, like insulin, giving somebody insulin, like giving somebody thyroid, right? These are medications that are very safe because they're just putting back what our body already made. So that's how I like to break down risks. And yes, of course, there can be risks in taking medications. By and large, for the FDA-approved hormone medications, when appropriately dosed, especially transdermal, meaning it's coming in through a patch, not coming in through your mouth, the risks are very low and very safe. Certainly safer than even birth control, which we give to how many millions of women.
So here I'm going to throw another one in the ringer. So there are places like the happy hormone cottages that they call them, I think. Are those safe to have those pellets put in? Because how do you know if you're...
Yeah, it's a great question. I'll take it, but I'll be short so other people can answer too. We actually have a lot of data on pellets. A lot of data going back to the 30s and to the 40s. So this isn't new stuff. And why it happened, why these happy hormone clinics existed, is because mainstream medicine basically shut down the availability of hormones nationwide after the Women's Health Initiative. So women are suffering. Women are looking for answers. And what these people did is they said, I'm going to help you. I want to help you. And they kind of marketed it using this bioidentical term, which we can get into. But they basically said, don't worry, these are okay. And that's how women kind of came into these, we'll call them happy hormone clinics. Well, they exist for a reason. A lot of people do very, very well on them. The concern sometimes is, number one, they're very expensive. I always say you shouldn't remortgage your house to treat your hormones, right? So there are cheaper insurance-based products that you can use. So that's number one, is just cost. And then number two, some people are getting what we call supra-therapeutic dosing, so higher than where kind of the guidelines are saying. And that's where we're pushing and kind of seeing those side effects a lot more than somebody who's on a product that isn't being supra-therapeutically dosed. But again, lots of people do well on those hormones too. And we do have decades of data. I've recently been deep diving into testosterone, so for your next podcast. But that's how I know, like, lots of people do pretty well, but not everybody.
It's a date. So I'm gonna hold you to that one, because I think we should do that one. Dr. Rubin, can you determine, how can a woman determine if hormone therapy is right for her?
So this is where education is so important. And actually, I'm so grateful to my doctors on this call, because it's really important for my patients to not do something because Dr. Rubin says it's a good idea. I actually want you, and I'll ask my patients, I'll say, how do you consume information? Do you like books? Do you like podcasts? Do you like written word, like blog posts, like Twitter? Like, how do you consume information? And I'm so blessed because I have incredibly smart colleagues in the field that I can give it, tell my patients to follow them, because it is really important that you really feel confident about your decision, because you will see headlines. As Kelly Casperson said, there are side effects to all medications. So if you start your estrogen and you get breast tenderness, instead of panicking and saying, oh my God, Dr. Rubin is trying to kill me, you have more knowledge to say, oh, wait a minute, I read about that this could be a side effect, and I heard from this person that could happen too. So that way you make more educated decisions as opposed to fearing that you went wrong, right, somewhere. And so education is power here. So for patients, doing your own research, but getting sort of someone helping you figure out, and a good place to go is sort of the Menopause Society, which is menopause.org, is to get a sense, are there menopause specialists in your area? Are they people who have really taken an interest in these symptoms and things about menopause? Now, even those people, no one doctor should be responsible for your whole menopause journey, or may be completely competent for your whole menopause journey. So we see people who go to these hormone clinics and get put full of pellets or something like that, and they're spending a lot of money, but nobody's looking at their bladder symptoms or their genitourinary syndrome of menopause symptoms, so their vaginal symptoms, their orgasm symptoms. And so you say, wait a minute, that clinic down the street, there's no urologist there, there's no urogynecologist there, they're not looking at me as a whole person, they're just looking in one way. So it's really important that you realize that in our medical field today, we don't have enough fellowships that really allow for a comprehensive view of the menopausal person. And also maybe, it's actually a disaster, because cardiologists must be taught about menopause, and they're not. Because when Oprah shows up to 5 cardiologists with heart palpitations, not one of them suggested perimenopause. And that's a travesty, right? And so when you go to the neurologist thinking that you have MS, and they say, well, you don't have MS, but they can come back and say, but hormones may be able to help all of your symptoms, but they don't, because our medical world doesn't teach the neurologist about hormone therapy. The rheumatologist who's dealing with joint pain can say, well, I don't think it's rheumatoid arthritis, but I don't know what's wrong with you. They then don't give them the answer, estrogen is going to fix your joint pain, nor do they know how to give you that estrogen prescription, because nobody ever taught them. And so people are showing up to their gynecology visit for 15 minutes once a year with their legs up in stirrups, and they're expecting knowledge of levels that their gynecologist just doesn't have, because of a study from 30 years ago. An entire generation of doctors doesn't know how to do this. So your endocrinologist doesn't know how to do this. Your rheumatologist doesn't know how to do this. And so it is imperative that we create fellowships. It is imperative that we create people who can do this work deeply, right? And that you as a patient need to seek the people who know how to do this work deeply. And sometimes that means traveling. And sometimes that means getting multiple opinions from multiple people. And it is not fair. And it should anger you and upset you. And that is why we have to do more advocacy and outreach and yelling and screaming. And so we have, again, long-winded, we have a lot of work to do on this side of things. But sometimes if you're in the middle of Idaho and there is not a menopause practitioner in your local area, you got to seek, you absolutely, it is between life and death for you to go get a better opinion.
I love this show. This is my favorite one. Good
mic drop.
grief. Awesome. It is a mic drop. Okay. Here's the next question. So Dr. Vaccaro, is there any risk of hormone therapy? What are the risks?
Yeah, so to kind of tag on to what Dr. Rubin's already said, this whole WHI study that came out actually when I was in medical school, that really, I mean, it was all over the news. It was headlines, it was, broadcast. I mean, it was huge news, which terrified all women. They basically said, women are going to get breast cancer, women are going to get heart disease. It's not safe. We should take all women off hormones. They're going to get blood clots. So all these things were just blasted all over, and they were really, really did a huge disservice to generations of women and generations of physicians. There's, just now deserts of physicians where we just don't even have any physicians that even have been trained, like Dr. Rubin said. So I think, there's great a video that I actually love that goes over all of the data is a video called Hot Flash Havoc. It's a 90-minute documentary that kind of goes over hormone replacement therapy, the Whi study, and it really breaks it down even more than we can talk about in this podcast. And I highly recommend it for any woman who's considering hormone therapy, who's on the, on the cusp of what's right for her, because it just gives education. As Dr. Rubin said, education is power. So I highly recommend that. But again, the risks are extremely low, like Dr. Casperson said, as far as any medication. Hormone replacement is bioidentical. All the FDA products are bioidentical, meaning, and all bioidentical means is really the hormone fits in the receptor. It's going to make the changes and support the body the way our natural hormones would do. So very, very low risk. But we do know for certain types of hormone therapy, like Dr. Casperson said, the transdermals are the safest. So anytime we do a patch, a vaginal ring, a gel, those have the absolute lowest risks, and that decreases, really the risk is decreasing an extremely low amount of strokes and blood clots. And I'm talking, a few per 10,000 woman years. Okay, so it looks like it's a big number, but it's actually extremely, extremely rare to get blood clots on hormone therapy. But doing a transdermal product does reduce that risk significantly. Localized therapy, though, so applying cream, tablets, rings, etc., to the vagina, those risks are extremely, extremely low. And we even now know that even women with a history of breast cancer, they're safe to take localized hormone therapy, which helps also the neighboring tissues like the bladder. But I do want to be very clear, if you've had a history of breast cancer, the risks and benefits and alternatives do need to be discussed with your cancer doctor as well, just to make sure that everyone's on board with that plan. Lastly, on touch on pellets, I know we've already touched on pellets a lot, but I just saw a woman in my clinic that had scars all over her buttocks because of multiple pellet injections, because again, these have to be done every few months to maintain the levels. And she showed me her hormone levels, and her testosterone was 5 times the normal amount for a woman. And she was starting to have, facial hair and other changes. So I just a word of caution again, that pellets work great for some patients, but they need to maintain the hormones in an appropriate range for a woman.
Can I say a quick word on pellets? Because I think there's been a good discussion here. And I want to be very clear. We have an FDA-approved testosterone pellet for men. It's called Testapel. And they did the work. They did the FDA-required steps to have an FDA-approved product for men. It's not the only testosterone product we have for men, but it is a product for men. And so if pellets have been studied since the 1930s and 40s, if there's adequate data and research, and if we have it, then do the work and get the regulated things that go into place to have the FDA put their mark of approval. So I think it's really important that we as advocates really shame these pellet companies to say, shame on you for doing this unregulated stuff that you're doing. If you're so confident that your products work, and I don't disagree that their products have validity to them, do the work to show the safety. I mean, you're talking, my kids' applesauce pouches have been recalled because there's poison in them, okay? So you're implanting something into your body that no one's looking under the hood, no one's regulating, no one's making sure there's no poison in them. Shouldn't that outrage us as a society to say, do the work, right? Like we have rules in place for a reason, to keep people safe. And so can we guarantee your safety? We can't. We can never guarantee your safety fully, but that's why it's really important that we understand the risks and the benefits.
I love that. And I will add, why do we care? Why do we want FDA approval, right? And I think Dr. Rubin said it, number one, is the amount of safety and regulation that goes into an FDA approved product is above and beyond what you can get, what we call off label, or the companies that don't go through the quality control. So number one, safety and a standard. But number two, once you have FDA approval for a product, it legitimizes insurance coverage for it. And that is incredibly important for not only access, but equality to these products. We have FDA approved testosterone for men, which means insurance covers it. This stuff is cheap. We do not have an FDA approved testosterone product for women, which means it's expensive, out of pocket, and limits access to the majority of people. Like I said, these are hormones that you're not going to take for a weekend. Ideally, you're going to live a long, thriving life. And these are medications that are long-term and safe. You shouldn't have to remortgage your house or use an off-label product to get the same kind of quality of life that we're given to the men over here.
Women, are you listening to
Love
this?
it.
We have to do something. This is not fair. Dr. Casperson, what do you do with patients that need other treatments than having hormone therapy? Is there another way if they just cannot do the hormone therapy?
Yeah, it's a good question. I think of that in two ways, because I actually think there's more women who think they can't have hormones that can actually not have hormones. So my first question for a woman when she's like, I can't have hormones, is I say, why can't you have hormones? Because I want to understand where that absolute black and white came from in her mind, so that I can then educate her to be like, your great Aunt Susie who smoked, 40 packs a year and had breast cancer is not a reason that you can't be on hormones, right? So first of all, I want to clear up, because I think the amount of women who actually can be on hormones is bigger than what people think. And then number two, there are some people, another time for a podcast, because it's very fascinating to talk about what are we doing to the 5 million breast cancer survivors in this country who are having devastating low hormone effects, that we are treating some of them, but that's not standard, right? So that's another conversation, much, more nuanced. But then we do have, there's a new FDA approved product called I'm going to kill it, but Venzoa, Festo, help me out.
Veoza, I just call it Veoza.
Veoza, okay, thank you.
Yeah.
So works in the brain centrally, non-hormonally for hot flashes. Does it work better than hormones? No. But is it great to have a non-hormone option for people who can't take hormones? Absolutely. Brand new medication. We're going to, like any medication that's brand new, we don't have lots and lots of years like we have the decades for the hormone, stuff. But it's great to have an option. I think as far as, and just to talk quickly about genital urinary syndrome of menopause, we do have non-hormonal overactive bladder options. See your local urologist, they know all about that. Moisturizers can go a long way as far as comfort, certainly lubrication. So there are things that can improve your quality of life. It's not so black and white that you have to take hormones or you're not going to get any relief.
There you go.
And Patty, I would like to just chime in there because I think the women that either feel that they can't or they're still afraid, because I think there's this huge fear-based approach as well to hormones still. What I tried to explain is we can certainly treat them non-hormonally, but it's going to take numerous different medications or other products. So, paroxetine, which is labeled for hot flashes, is an antidepressant. Veoza also works kind of at the neurotransmitter level, but then they need something for their bladder, sometimes, an overactive bladder medication, something for their vagina. They need something for their eyes because they have dry eyes. They have, their skin start changing, their bones start losing. They need a bone medication. So they're literally all these other medications that they need to take with all the risks that go into all those different medications, whereas everything could be kind of treated with one medication, which is hormone replacement, that actually physiologically supports the whole body. So I just try to break it down for them and help them realize the differences between all the medications that are possible. But certainly Veoza is really new and hot flashes are one of the most bothersome symptoms that women do have. So I do appreciate at least there's been some movement in that area.
Look, the way I'm seeing this right now is any woman coming in to see any one of you would be lucky. Not everybody has you. So, Dr. Rubin, I'm going to start with you. How does she start this conversation with her doctor? What should she be asking when it comes to the menopause symptoms? And if they're not answering, these A, B, and C questions, is it time for her to look for somebody else? I know that travel is sometimes important if you live in some boho town where there's not a good doctor available, but can you help the listeners out there? What are the questions she should be asking? How does she find somebody that is reputable, that is going to help her?
Yeah, I think the Menopause Society website is the first place to go, right? Menopause.org. If your provider has taken an extra test, an extra certification where they really care about this, that's a really good start. If you don't, there's not that many names on that list, actually, which is a problem and something where we have to work on our end to really teach our clinicians how to do this. There are some very cool new and I'm not going to say any particular one that is better or worse, but there's a lot of tech involved now in terms of companies that are doing virtual care to try to help people that are a little bit more algorithmic based. And really they have good people leading them to help with menopausal answers. And I think it's, if you see a clinician who's going to only spend 10 minutes with you and dismiss your symptoms and tell you that it's not that serious, if they make you feel small, if they don't look like, if it's all or nothing of you can't do this with your body, this is not safe, it's okay to nod your head and smile and seek care elsewhere. And I think I always tell people when they end up in my office, like, they don't come to me with little problems. Nobody travels from far away and waits 6 months and to see me with small problems. These are big problems. And anyone who makes you feel that this transition in perimenopause and menopause is a season and that it's the small thing that you shouldn't be bothered by, time to find a new clinician and advocate for yourself. Now, if you see someone who doesn't necessarily have all the answers, but is really interested and learning, and they're not afraid of your questions, and they have thoughtful responses, those are the people that you should definitely keep going back to. And when I say keep going back, don't actually bring this up at your well woman's visit when you're getting your pap smear and your mammogram. Make another appointment, whether it's with your primary care doctor or your gynecologist or your endocrinologist. Make a separate appointment to talk about menopause symptoms and use that as an interview where you are interviewing them to see if they are the appropriate partner for you managing this life change. And at the end of the day, this is your body, this is your choice, and you get to decide what risks, what benefits, what you want to put into your body. So never let anyone tell you no. Now, there's going to be doctors who tell you, well, this maybe, given your history and everything I've heard, maybe I would recommend X, Y, and Z, but you are the boss. You are the CEO of your body, and you bring in different people into your C-suite. You bring in different people as consultants, and then you get to decide who stays and who goes.
I love that. That is so empowering. I love it. I would add tips and tricks. Read the books, listen to the podcast, follow the people on Instagram who are reputable, get your education as much as you can before you go in to see your doctor, nurse practitioner, provider, because a level of conversation you can then have. Women are smart. They read, they can process this information. It should not be behind a paywall that only somebody who went to these schools has. And that's what we're working so hard to provide, right? So get your education so you can have that higher level conversation with your provider. That's my first tip. My second tip, I don't want to say it's fail proof, but this works very well for doctors, is you say, how about we just try it for a couple of months? And then I will come back. And then we will figure out what to do next. Like, that is showing partnership. That is showing follow-up. That is showing, you know what? I don't know if this is right for me or not. Can we just try it? I'll come back and I'll let you know how I'm doing. Like, that works pretty darn well instead of this, like, should I, shouldn't I? It's black and white. It's a much more nuanced, collaborative conversation. And for me as a doctor, like, when people come in and they're like, can we just try it? I'll let you know. I'm like, absolutely. So to me, those would be my additional tips and tricks.
And I'm going to throw in a few more, Patty, just because as I am this age, all my friends, colleagues that I've known forever, right, are this age. So I get calls from my friends all the time. You know, what do I tell my doctor so they'll give it to me, because they're not giving it to me? And I literally feel like I go through the coaching, the talking points, you know, Tell them you have bothersome hot flashes. Tell them how it's influencing your sleep, that you're getting woken up at night, that you're feeling fatigued because you're not getting good sleep, et cetera, et cetera, et cetera. It's almost like they need to come in with a list of their symptoms, starting with hot flashes, because generally that's the one that most doctors are comfortable with treating. It's also tailorable because it's a symptom that once you get enough hormone, the hot flashes go away or they're very rare. So it's something that you can tailor the therapy to get the symptoms to go away. So I feel like I'm always coaching people because, again, doctors sometimes need all the symptoms to feel comfortable with the prescribing. But I love Dr. Casperson's just like, just let me try it. Let me just see how I feel. Let's just do a trial and I'll follow up. I love that tip. So
I do too. I think people who might be uncomfortable would be comfortable with that. Let's touch base again in a couple months and see how this is working for you. Dr. Vaccaro, is there anything else our listeners should know about menopause or hormone therapy before we close the show?
I think if there's one thing to hear is that hormones are not scary. And in fact, the Menopause Society has published excellent guidelines that hormones are first-line therapy. I'm going to say that again. Hormones are first-line therapy to treat menopause symptoms. And given started within 10 years of menopause are extremely safe and beneficial to quality of life. I think, again, sometimes patients and providers think that they need to fail, behavioral management like layered clothing, cool your bedroom, have a fan nearby, all these sort of things before they can go to another therapy, just even non-hormonal medication. And it's the algorithm's backwards. Hormones should be the first line therapy offered because, again, it supports the whole body. I sincerely hope that women and physicians become less afraid of hormones. I think my colleagues here do an excellent job at getting the word out. They're again huge on social media. I recommend following them because they are passionate and they're getting the word out. And I hope that through their passion advocacy over time, hopefully soon, I do see the pendulum swinging, that physicians and women become less afraid and more acceptable of hormones. Because, again, who doesn't want to enjoy a great quality of life? We know menopause is going to happen, but the symptoms can be relieved with adequate treatment. And just like we always say, Patty, if you're having trouble finding a doctor, break up with your doctor or keep searching. Go to the Menopause Society for providers that are certified. And I can't speak again highly enough of that video, Hot Flash Havoc. It's a really wonderful documentary, reviews all the data. It's a super fun way to review the data too. It's not, sterile doctors talking. It's actually real women talking about their experiences, and some who opt and some who don't opt for hormones and why they choose what they chose. So I think it's a really nice balanced approach that looks at it. So again, be your own advocate. Quality of life's worth it. And I do want to let my colleagues, say a few last words too. And I just want to thank them immensely for their time. So Dr. Rubin, do you have any final last words?
I agree with all of it. Two things. One, don't suffer. This idea that we as women inherently must suffer to protect and take care of everybody else is really needs to change. You got to put your oxygen mask on, and you do not need to suffer as a way to prove to other people how strong and great you are. There are so many things that are safe. They are safe. They are safe that you think are dangerous, that are safe, safe, safe. And just a little explanation can go a long way. And number two, in addition to the Menopause Society website, I want to put a big plug to ISSWSH, ISSWSH, which is the International Society for the Study of Women's Sexual Health. So ISSWSH.org has a Find a Provider. And so you will find Dr. Casperson and I on maybe Dr. Vaccaro soon, if not right now, on both websites of the Find a Provider. Because if you care about, not everyone in the menopause world cares about sexual health, but everyone in the ISSWSH world, the Women's Sexual Health Society, cares about menopause. And so if you can find a provider there, those are two great websites. So sex and menopause go together, right? And so if you care about your sexual health, if it's something that's important to you, it should be important to your doctor. And so ISSWSH is a great place to find a provider who will care about both your menopause symptoms and your sexual health symptoms. And a full disclosure, I am the outgoing education chair of that society. So I'm very biased and I love that organization very much. And if you're a clinician listening, please, we need you to join us because we need your voice to help more people.
And you'll
Thanks.
see us at the February annual conference in Long Beach. So if you join. My final thought, if you want it, is I want to speak to the women. They certainly live where I live. I'm West Coast, Pacific Northwest. These are the women who think natural is better, and that because menopause is natural, we shouldn't treat it. And this is called the naturalistic fallacy. It is the belief that because something is natural, it is inherently superior or better. I love the psychology of this. But I get that. I see so many women who are like, I'm not on, they're very, very proud of not being on a prescription medication. I get it. I identify with that too. And I want to break that down for people. Our eyesight changing is natural. We don't tell people not to use glasses. Our tooth decay can be natural. We don't tell people not to floss. And I have 2 vibrators for my mouth, an electric toothbrush and a water pick, right? I'm not going to let natural happen to my mouth. And so once I drive a car because it improves my quality of life. I wear shoes because I want to protect my feet. Barefoot is natural, right? And as soon as you kind of crack open what that myth of natural is, it comes falling down. I'm wearing clothes because I don't like being cold. Being naked is natural, right? Like it just does not hold up. And I want to encourage women to say, when you associate menopause with natural and therefore you should or shouldn't do, you're really limiting your quality of life in an area where you're not otherwise limiting your quality of life for other natural things. And I just really love that thought experiment to help open up their curiosity of what they can do to improve their quality of life for midlife.
I so love that. Thank you. I'm going to use that.
Yes.
I got Patty to have a jaw drop, so I've done my work here.
Oh my God, I love this. The most frequently asked questions when it comes to sexuality, sex, we don't talk about it. We put it on the back burner. And that's why I do what I do, because I don't know if there's still so much shame attached to pleasure. I don't get it. But they're questions that, you're right, the grandparents, the parents, the kids, they're all asking. And why are we not making this a priority? Because it's part of our happiness. It's part of who we are. And I don't get
Well,
it.
and in menopause, speaking of, Kelly says, right, we somehow made women afraid of a hormone that's already in their body, right? So sex is this thing that everybody has, and we make people afraid of it and think that somehow it's wrong or perverted. Yeah. And yet that's the only way we advance as a society, like as a species, which is like, you can't make this stuff up. It's so backwards. Like that's what makes it so fascinating.
I think about that a lot, Patty, like, because I'm like, why can't we have the conversation where you as an expert, we as an expert want to be? And it's because they're missing the basics. They don't know where the pee hole is. They don't know where they're grown men who don't know where a clitoris is, right? So we're like, pleasure, enjoyment, equality, like we're kind of coming in, we think we're coming in where we are, but we're kind of coming in high level a lot of the time. And like the questions from the kids and the stuff on the Instagram, it's like, we so often forget the basics. The ground floor has not been laid.
Yeah, I agree with that.
The foundation, for sure. Like that's where it's what you're doing, Patty, is just so important, right? Because you're creating the foundation.
It's what we're all doing. It's trying to get that message out there and taking the shame out of it, and saying it's okay to prioritize your life, your sexuality. It's okay. And there's nothing to be ashamed of. And I've tried to teach this, and I think that's why I'm so close with grandchildren, is that they know they can come to me about anything. And we can, there's times I hold my breath and I go, what? But I'm glad I've always been there, and I can still be there to let them know it's okay. It's all right. It's fine. All right.
I think it's fun to see the big revelation of like, when people talk about it, they didn't die, right? They're like, I didn't die. And you're like, yeah, it's a conversation. But like, once they get over that, then they're super curious, so
right.
It's fun.
Yeah. But you know what? I know that this will have an effect, the way that I've spoken to my grandchildren, my children later, my grandchildren really early. And so this will go on for generations. hopefully all of them will carry this forward and say, hey, we're not gonna have a household where we're shamed of sex or feel ashamed. And I want you to know you guys can come to me and talk to me about anything. So if, I've done anything to kind of stir the pot, that would be it right there.
Which is such a great legacy. I love everything you do. Seriously.
I love you guys. I couldn't do it without you. You are the superstars because you're the ones that everybody wants to hear and talk to. And this is fuel for me, because I've worked with so many women over the years and so many of them that come up and tell me their secrets. And I love that I was able to start Pure Romance, but this is really my passion now. And I think that we have to, our voices have to be heard. We have to make these changes. And it's not going to happen in my lifetime, but I can be the start of it. And so it doesn't keep going generation after generation. Women deserve to have this information. Our doctors deserve to have the information. So yeah. Thank you for everything that you do to help women. You guys are, when I say rock stars. And any woman that comes into any one of your offices is so fortunate. I got to say, of all the shows, this is probably my favorite one. So and I'm sure it will be for the listeners too, because it's going to happen to all of us. So, today, I want to thank my guests, Dr. Christine Vaccaro, Dr. Kelly Casperson, and Dr. Rachel Rubin for a great conversation. And if you like what you heard today, please rate and subscribe to our podcast. For more information on the Patty Brisbane Foundation for Women's Sexual Health and our focus areas, visit the pattybrisbanefoundation.org. Remember, sex care is self-care and sexual health matters. Thank you.